Just by way of an outline to give us a feel for where we're going to go tonight, we're going to talk about the scope of the problem. I'm going to focus today on lower extremity PAD. The definition of PAD, just before we get too far in, is any sort of blockages that develop in the blood vessels outside of the heart is considered in the periphery or peripheral arterial disease. That can include neck artery blockages, that can include blockages in the arms, in the abdomen, the kidney arteries. But tonight we're going to focus on those blockages in the legs and those symptoms that occur with, related to symptoms in the legs and other things that we'll be dealing with there. So we're going to focus just on that for tonight. We're going to talk about the overall awareness or lack thereof about PAD in the community and amongst physicians at times, and what is the impact of PAD on patients. We'll talk about what are the symptoms of PAD or lack of symptoms for many patients, what the exam would entail, and what sort of testing should be done to make the diagnosis of PAD. We'll talk about the treatment of PAD, including some lifestyle changes, role of medications, and then potentially in some patients, role of doing type of interventional procedures like ballooning, stenting, or surgery. And then we'll summarize. If we have a few minutes, we might get to the case review, but I think we'll probably stop there and allow some more time for some questions, okay? If there are questions, I'd love to take them. We can take some during the talk. Otherwise, we'll do that at the end, all right? All right. So first thing to leave here with is PAD is a very common problem, okay? So if you look at it, the numbers here on the screen, 8 million people, some estimated up to 12 million people in the United States with PAD. So this is not a rare diagnosis. 1 in 3 people over the age of 70 have PAD, and only about a quarter of those are actually undergoing treatment, and many of those don't complain of the classic leg pain symptoms, which would bring the diagnosis to the attention of the physician. So it's very common and under-recognized, and I'll show you some more slides on that in a minute. If we look at it with regards to, or in comparison to, you can see PAD is more common than very common diagnoses that you think of, like cancer, stroke, and Alzheimer's disease, with about a 12% of patients with PAD. Obviously, coronary artery disease and diabetes are slightly more common, but you see PAD is a very common diagnosis. Who gets PAD? What are the risk factors for developing PAD? If you leave here remembering 2 things, it's smoking and diabetes are the 2 most common factors that drive the vast majority of patients that have peripheral arterial disease involving the legs. Other risk factors are listed there. You see obesity, high blood pressure, high cholesterol, advancing age, as I mentioned, 1 out of 3 patients over 70 have blockages in their leg arteries, and then a family history. So genetics obviously plays a role in this as well. Most of these factors on the left side of the screen lead to that top diagnosis of atherosclerosis, or buildup of plaque within the arteries. That can be calcium, that can be cholesterol, plaque buildup, but other things can cause it. So not all patients have to have all of these risk factors or any of these risk factors. Patients over there on the right side that have blood vessel inflammation, so patients with diagnoses like rheumatoid arthritis, patients that have lupus, other things that cause inflammation in the body can lead to blockages in the leg arteries. Patients that have had injuries to their legs, actually took care of a patient who was a soccer player in his younger days, had not warmed up much, went out and did an explosive kicking motion, ripped his quadricep muscle off his kneecap, off his patella, and then over time developed severe scar tissue in that area and actually caused narrowing down of just that specific artery in that location. All of his other arteries were totally normal. So injury, trauma to that area can cause it. And then radiation exposure, especially up in the head and neck. Again, we're not going to focus on that, but patients that have had head and neck cancer, they've had radiation, sometimes can lead to scar tissue and buildup of plaque within other arteries. So again, smoking and diabetes, the 2 most common things that lead to most blockages in the leg arteries. Yes?
Male versus female?
Yeah, so about equal, depending on the age as well, obviously, just like with coronary artery disease. So men tend to predominate a little bit younger ages, women sort of catch up as they get a little bit older. All right, so who should we be thinking about in these high-risk categories? Okay, so when we start thinking about who should we really be asking questions of, who should be bringing some of these some of these symptoms to their physician's attention. So if you're over 50 and you have diabetes, again, one of the most common risk factors, and 1 additional risk factor, that's considered a high-risk or at-risk patient population. If you're between 50 and 69 and you have a history of either of those 2 that I mentioned before, either smoking or diabetes, again, high-risk patient population. And if you're over 70, again, high-risk patient population. If you're not in these groups, but you have some symptoms that we would be worried about, such as walking impairment, so pain in the legs when you're walking, pain at rest in your legs, or having any non-healing wounds in the feet or legs, that would put you obviously at a higher risk of having PAD, and you should bring that to your physician's attention. Patients with, again, blockages in other vascular beds, heart, neck, kidney arteries, other places may be at high risk of having blockages in their legs as well. Okay? So I'm sure if you look down this list, either you yourself or you know someone probably that falls into one of these high-risk categories. I'd be quite sure about that. So you should be thinking about those kind of symptoms when you see your physician or just in your daily life. Okay? All right, so what is the overall awareness of PAD? I already mentioned that it's common, but obviously part of why we're here tonight, and I appreciate being here to talk to you about PAD because it's an important issue to raise awareness about because it is so common, but we're not very aware of it both amongst patients and physicians. So let's talk about that a little bit. So this was a study where they did a telephone basically call to over 2,000 patients. They asked them about PAD, what do they know about PAD, what is PAD. Only about a quarter of those patients, so 26% here, reported even any awareness of PAD. So the fact that you all are here and learning about this tonight puts you way ahead of the curve compared to most of these patients. Of that 26%, only a fifth of those had received any information from their healthcare professional, which is too bad because many of these patients, obviously they're over 50, many of them probably are at risk for having PAD, but it's not been discussed with them previously. And they also many were not aware of the fact that it's associated with a much higher risk of heart attack and stroke. Another really important point I want to make tonight is not just about identifying the blockage in the leg and treating that, it's also about making sure that the diseases of the heart, neck arteries that lead to stroke and heart attack are being managed as well because they do so commonly run together. All right, so we looked at another study. This is an often cited study in the PAD literature. So about 7,000 patients over 70, again, a high-risk group. I mentioned that already. 50 to 69-year-old group with diabetes or smoking, again, considered to be a high-risk group. And I mentioned that sort of number before, but this bears it out as well. About 30% of those patients had PAD. So again, that 1 out of 3 number of, again, over 70 or in this high-risk patient group have PAD. Interestingly, about half of them, the bottom number there, 56% of them also had coronary disease and peripheral artery disease. So over half the patients that had leg blockages also had blockages in their heart. So many times when patients are referred to me to discuss their leg artery blockages, I'm obviously very careful to ask them questions about their cardiac history, any cardiac symptoms, uncover anything there that may be important. I talked about the lack of physician awareness. So in this study, only just under half of the physicians who were taking care of these very patients that they interviewed knew that they actually had PAD or had a diagnosis of that, which is pretty striking. Okay, 2 things that happen with patients with PAD that we really want to bear in mind. One is that it can cause symptoms. So obviously it can cause pain in the legs, and I'll talk a little bit more about the symptoms in a little bit. But when people begin to have pain in the legs, they can become more sedentary, right? Less exercise, decreased quality of life. That can obviously lead to depression. In the worst case situation, it can actually lead to an amputation, which obviously has a very significant negative impact on patients' quality of life. Those are symptoms related directly to the blockage in the leg. That being said, I think maybe as important, if not more important, are what's going on with the heart and other vasculature. And obviously, I'm a little bit biased because I come from a cardiology background. But that being said, it's very important to point this out because patients that have leg blockages, and I'll show this on the next slide as well, have a higher risk of chest pain, angina there, 2 to 3 times higher than the average population, a 2 to 3% annual incidence of a heart attack, and it's unfortunately the most common cause of death being cardiac. About 40 to 60% of patients with PAD actually die from a heart-related issue, not from their legs. Okay, so very important to make sure we understand the link between the leg artery blockages and the risk of heart disease. When we look at that a little bit differently, if you look at we'll focus on the top row there. Patients with PAD, so leg artery blockages, are at 2 to 4 times a higher risk of having a heart attack compared to the general population of patients that doesn't have PAD, and they're at 2 to 3 times higher risk of having a stroke compared to the general population. All right, so I think we've hammered home, hopefully, this is a common problem. We're not particularly aware of it, both as patients and physicians. You guys are more aware today, and the important impact of PAD, both on your quality of life, but also on your heart and other vascular risks. So let's talk about the symptoms, which is important, what your doctor should be doing in terms of the exam, both in the history and physical exam, and then what sort of test should be done as an initial diagnostic test. All right, so the presentation of PAD varies, and in fact, and I'll show you on this next slide as well, the vast majority or a large proportion of patients are actually asymptomatic. So they may have leg artery blockages but don't have any symptoms related to them. It's still an important marker for increased risk of heart and vascular events, so it's still important to identify. In those patients that have symptoms, many of them will have more atypical leg pain symptoms. Well, let's talk about what a typical leg pain symptom is first, and then we can describe a little bit more what an atypical symptom would be. A typical patient with claudication will complain of pain or discomfort, usually in the muscle. It hurts them typically when they're walking a certain distance. When they walk that certain distance at a certain pace, it typically will reproducibly cause that pain, which often causes them to stop. When they stop, it takes several minutes typically for the pain symptoms to go away, and then they can resume walking. In a patient with typical claudication, they'll walk that same distance again, that pain symptom will come back again, and they'll have to stop walking. The reason the pain comes is because the patients are having a lack of blood flow to that affected limb or to that muscle. As you're exercising, right, you need more oxygen to go to that particular muscle. If there's a narrowing of the blood vessel, you can't deliver enough oxygen. Ischemia or lack of blood flow problems begin to develop, and the nerves begin to sense the pain. Patients with more atypical symptoms may have some of those symptoms, but not necessarily follow all of those exact symptoms in terms of having it every time they exercise, or maybe it takes different times to go away each time. But the vast majority of patients, again, don't necessarily have symptoms, and even those with intermittent claudication, those patients with symptoms, many of those don't have the typical claudication symptoms. The reason that's somewhat important to point out is that when we go through, read our textbooks, we hear about patients with claudication. They walk a certain distance, their calf hurts them, they have to stop, then our antenna really goes up. But we need to be tuned into other types of leg pain symptoms, things that may be limiting patients. They may interpret it as a osteoarthritis in the knee, and I had a patient who for a year and a half was treated for hip issues orthopedic-wise, and turned out she had a severe blockage in her leg artery, so it can be missed and interpreted as other type of musculoskeletal complaints, not necessarily related to blockage. So we need to be tuned into that. Critical limb ischemia is sort of on the very advanced end spectrum of patients with peripheral arterial disease, and that results in a really severe mismatch or lack of blood flow relative to the needs of the tissue. That can result in pain at rest. It can result in a non-healing wound, and obviously in the worst situation, gangrene. Fortunately, only a small percentage of patients with PAD or peripheral artery disease present with these type of symptoms, and that's about 1 or 2%. So just to show you a little bit in a different fashion, again, about half patients are asymptomatic. Only about 15% sort of read the textbook and kind of come in complaining of the very typical symptoms. A large portion, a third of those patients that have symptoms that have PAD actually will have more atypical type symptomatology. Again, some funny leg pain, something that's limiting them, but they can't quite describe it in the very typical fashion. Then the small percent of patients with critical limb ischemia. All right. Yes. Yeah, so valves are mostly, you have valves in your heart, obviously, yes, and you have valves in your veins. So the veins are, yeah, so maybe I should take a step back and talk about the blood flow and how that is supplied to the legs. So arteries carry blood. I always think of it when you're teaching as away, artery away, starts with an A, so it takes the blood away from the heart, and that's what we're talking about today. Peripheral artery disease arterial vessels take blood away from the heart. That's what we're talking about. Veins carry the blood back to the heart. So after it's been delivered to the tissues, veins carry it back. And those do have the valves that you're speaking about. Those type of valves actually work since there's no pump, obviously, down in your heart, in your foot to pump the blood back up. Those veins, as you walk, the blood is milked back up to the heart. The veins act sort of as a one-way valve when they're working to open, let the blood go up, and then instead of it falling back down your foot, they'll close, so it sort of goes up in a stepwise fashion. That's more on the venous side. People tend to have a lot of swelling in the legs, can develop wounds, et cetera, in the legs. That's a little bit different discussion than the artery side today. But many times those two can go along together. I see a lot of patients that have wounds in the legs, and they're often related to vein problems and arterial problems that we're talking about tonight. All right, one slide on just acute limb ischemia. So everyone knows symptoms of heart attack. We talk about that frequently. Chest pain should come in immediately. It's an emergent medical issue. Strokes we talk about. We tried to coin the term brain attack, which never really caught on very well. But this is a leg attack. So you can actually have a blockage in your leg that occurs acutely, just like a blockage in your heart can suddenly cause a cessation of blood flow to your heart, causing a heart attack. This can occur also in the leg. So if you suddenly have extreme pain in the sort of classic 5 Ps that we talk about of symptoms related to someone who gets an acute blockage in the leg, not one that we've talked about tonight where it's more chronic, gradually develops over time, but something that comes on all of a sudden where you begin to have severe pain. There may be no pulse in the foot. It may be pallor or pale, obviously. Paresthesia, sort of a tingling sensation, and then paralysis in the worst situation where there's just such lack of blood flow to the muscle that you can't even move the leg. If you have developed those type of acute symptoms, that's a medical emergency. You should call 911, come to the hospital immediately, okay? All right. When your doctor sees you, if you're in one of these at-risk categories, they should be asking you certain questions. I know there's a lot of words on this slide, but I'll just summarize quickly and say they should be asking you about pain in your legs. They should be looking to see if you have any non-healing wounds or ulcers, and I'll talk about the exam in a second. Any pain at rest in the leg or foot would be worrisome. I said we were only going to talk about leg artery blockages today, but when you're talking to patients about potential vascular symptoms, it's important to talk to them about other potential vascular problems. So patients that get pain in the abdomen after they're eating, that may be a sign of a blockage of the blood flow to the intestines through the abdominal arteries. Patients that have a strong family history of an aneurysm should also be discussed with the patient to see if appropriate testing would be needed. And then any sort of stroke symptoms should be part of, again, a careful vascular review of systems with your physician if you're in any of these high-risk categories. All right, so what about the exam when you come in to see your physician? They should be doing several things, especially, again, in these high-risk patients that we talked about. Should be checking blood pressures in both arms. They should be doing a careful heart exam, as I've mentioned many times. I think I've hit that point several times now, how important the cardiac involvement is potentially in patients with PAD. They should be feeling your abdomen to see if they can feel any sort of pulsatile masses that may be consistent with an aneurysm. And they should be listening for bruits. Bruits are sounds that, just think about a big wide river. When it sort of narrows down through a chute, causes a lot of turbulence, and we can sometimes hear that. Places that are close to the skin or arteries that are close to the skin, such as in the neck or down in the groin area, those are places where the physician can be listening carefully to see if there's any signs of turbulence or these bruit sounds, which may be a marker of blockages in those particular arteries. Careful examination, obviously, since we're talking about leg PAD or lower extremity PAD, would be to examine the legs and feet, take their shoes and socks off. Many times physicians come in, don't take their shoes and socks off. I think that's important. The pulse exam at the neck, the wrist, the groin, behind the knee, and then both pulses down that are palpable at the feet should be inspected in patients, especially those with high risk for having underlying PAD. All right, so what's the most appropriate test? So now we've talked about a high-risk group. We've talked about the symptoms that can come from it. We've talked about the questions that physicians should be asking. What test should they send you to? And most of the time, we sort of summarize it, and this has this very long name that we use a lot of time of a non-invasive lower extremity arterial physiologic study. I can't even get it out, and so we don't talk about that much. So what's actually used is ABI. So when you hear your physician say, hey, I'm going to get an ABI on you, or when I get referred patients, I ask them frequently, what did your ABI show? Let's talk about what that means, because this is the sort of initial sort of screening test once we have some suspicion that somebody might have PAD. And it's a really simple test. It can be done in the office. We do them. It can be done in the office just with a blood pressure cuff and a little Doppler machine, or it can be done in a more sophisticated fashion where we look at the pressure waveforms and some other things. But either way it's done, it's a great screening test. Basically what you do is you measure the pressures in both the arms, for both the upper extremities, and down at the ankle on both legs. And then you basically compare what's the pressure in the ankle relative to the pressure in the arm. And I talk about this with patients frequently. If you turn on the spigot, we'll say your heart's the spigot at 120, assuming that there's no blockages anywhere around the tubes or the hose that's going out from your heart, the pressure should be 120 or a little bit higher. There's a little bit of reflective wave which causes a little bit higher pressures in your extremities as you get further and further away from the heart. So any patient that has normal pressures, no blockages, should have pretty equal pressures in their arms compared to their legs. Does that make sense? So patients that have blockages in their leg arteries, it's like your hose. You turn the hose on, it's coming out full bore, all of a sudden nothing's coming out. What's happened? You got a kink or some narrowing in the hose, right? And that causes the pressure to fall. So if people have lower pressures in their legs, that's a strong indicator that they likely have blockages in their leg arteries. So simple pressure done in the office, both arm pressures, both leg pressures, and then we just compare them as a ratio. And we use these ratios to help us decide what the severity of the disease is. And this is not for y'all to memorize anything, but important just to point out one thing. Some patients have what we call non-compressible vessels. So in order to assess the pressure inside any blood vessel, you have to be able to stop the blood flow. And then as you're releasing the cuff, whatever that pressure is, that tells you what the pressure is inside the blood vessel. Patients that have very calcified blood vessels or really hardening of the arteries, we're not able to actually ever compress those blood vessels. And that happens frequently in patients with diabetes or patients on dialysis where we just can't compress the vessels, so the pressures in the ankles are artificially high. That should prompt us to do a different type of test because we can't really tell what's going on pressure or flow-wise with that type of test. But that's a small number of patients overall, and there's other tests that we can do to evaluate their peripheral arterial disease. If they're in the normal range, again, around 1.0, equal arm pressures, equal leg pressures, that's considered normal. They're mild to moderate range, so if your pressure in your legs drops by 50% or between 10 and 50%, that's considered mild to moderate PD. And patients that have really severe PAD, their pressure is less than 40% of what their arm pressure is or less than 0.4. A lot of times those patients will be the patients that have the wounds on their feet, patients that have pain when they're just sitting there even before they start to move. They can get obviously worsened when they're moving around. That's very severe PAD. All right, other tests that may be ordered by your physician might be an exercise test. So patients that have sort of normal or borderline normal resting ABIs, we may walk them on a treadmill. That can be important to bring out some drops in pressure that we don't necessarily see just at rest. An ultrasound, just like people have had potentially done of their neck or their heart, that can be done in the legs to look for specific areas of narrowing that might help guide treatment. And also in patients that have had a prior bypass procedure before, they can use that to sort of monitor the bypass and make sure things aren't narrowing there. And then there's MRI or CT scan, which can be helpful. The last test, which I don't have on here, would be to just do what I call a conventional angiogram. We actually put the tube directly into the leg and take pictures by injecting dye and using an X-ray camera. That's frequently done in patients with more advanced disease and whom we're thinking about what are options for treating these particular patients. And I'll talk more about that in a minute. All right, so speaking of management of PAD, I want to focus on two things. And I've started the talk this way too by saying, hey, we should focus on what are the symptoms caused by PAD, the leg blockages. Yes, that's important because it can cause a significant decrease in people's quality of life. So we want to improve blood flow to their legs so they can walk more and be more physically active, but also making sure that we're paying close attention to their heart and vascular risk just because of the fact, obviously, that they have a higher risk of having heart attack or stroke. So 3 things. We'll go over them sort of in summary here, and then we'll have 3 slides addressing each number 1, 2, and 3 here. So number 1 on the list, lifestyle changes. I know many times you come to the physician, it's take a medicine, see you later. I think it's super important, incumbent on all physicians to really focus on these lifestyle changes with patients. I think they have an enormous impact on patients' health and outcomes, maybe even more so than many medications. So right at the top of the list, and we'll talk about this a little bit more on the next slide, I think, is smoking cessation. Patients with PAD have got to quit smoking. It's the number 1 most important thing, the thing I drive home with all of my patients because it's so common in patients with PAD is you have to quit smoking to stop the process. It actually allows some more healing in those blood vessels over time, and importantly, obviously reduces your risk of having a heart attack or stroke, which is important as well. Supervised exercise programs, so there's actually been studies looking at supervised exercise. So you actually go in, just like with cardiac rehab or physical therapy, have a trainer sort of pushing you, and actually is shown to improve patients' walking distances more so than just saying, hey, go exercise. Unfortunately, Medicare and other providers haven't caught up to that information and aren't paying for it, so that's the unfortunate piece of this puzzle. But an exercise program is definitely an important piece, whether or not it's supervised or on your own. But exercising, walking more will help. It helps in 2 ways. Number 1, it helps by actually growing blood vessels. So when patients would go, in some studies, get a biopsy of their muscle before they start an exercise program and after, the number of little blood vessels that are adjacent to the muscle cells in the muscle go way up after you've exercised for a period of time. So actually grow new blood vessels in your legs can improve symptoms that way, A. And B, it just makes the muscles more conditioned, right? When someone starts training for a marathon, they can't run a marathon the first day, but their muscles become more efficient over time. So it allows patients' muscles to become more efficient and increases the supply of blood. So exercise is super important. And then healthy diet. And I am definitely not going to wade into what's the most appropriate healthy diet because there's so much information flying around out there. And one day it's eat this, then it's don't eat that. And I don't even know what the right answer is. I think there's some tenets around, trying to avoid eating out, trying to avoid a lot of the fried foods and a lot of the whites and certain foods, a good, healthy fruit and vegetable diet. But aside from that, I'm not going to make any specific recommendations tonight. Medications, we'll talk about that a little bit more on the next slide. That might be statins. I know it usually draws a little ugh from the crowd because of all the potential side effects of statins, but they're very beneficial in the vast majority of patients. Blood thinners, which I'll talk about, and then symptomatic relief. There's only one drug that really helps to relieve the pain in the leg symptoms when people are walking, and that's a medicine called cilostazol. And then we get to angioplasty and surgery for those really advanced patients doing the ballooning, stenting, or maybe bypass to help relieve symptoms. Again, the number 3 doesn't treat the heart issues, it just helps to relieve the symptoms in the legs, which can be important because then you can exercise more. Feel better, exercise more, still reduces your heart risk. All right, lifestyle changes, just to reiterate, I think I hit on all of these on the previous slide, but the diet issue, which I'm going to steer clear of, smoking cessation, I can't emphasize that enough, how important that is, the exercise piece of the puzzle, and diabetes therapy. So not just obviously controlling the diabetes, which is really critically important to this process as well, because diabetes not only affects the big blood vessels that I can put stents in to help relieve symptoms, but those little small vessels that we can't do anything about that can really lead to a lot of symptoms and bad outcomes. So super important to keep the diabetes under good control, but also specifically to leg blockages in patients with diabetes is making sure you maintain really good foot care. I'm always checking patients' feet, making sure that they're wearing shoes all the time with a solid sole, not walking around barefoot, having friends or family or themselves keeping close eye on their feet because they're definitely at increased risk for developing wounds and ulcers that might not heal. Okay, medical therapy, and again, a lot of this centers around heart risk reduction, right? I've said that many times, how important it is to reduce your risk of having heart attack or stroke. So that might include statin medicines. Statins have been well studied in patients with leg artery blockages and help to reduce the risk of having heart attacks or strokes, so very important. Keeping your blood pressure under good control, obviously, is very important. And then preventing clots from forming, both, again, heart, legs, and into the brain with a variety of different potential medicines. I'm going to touch on a research study that we've been working on at Duke that I'm excited about, and it's going to be coming out soon in just a moment. And then reducing the leg pain symptoms. I mentioned cilostazol. So that's the only medicine that's been shown to actually improve the distance that people walk. Is it a cure? Unfortunately, the answer is absolutely not. In studies after about 4 to 6 weeks, so people have to tolerate for at least a month or so, after about 4 to 6 weeks, their walking distance improved by about 50% on average. So not a panacea, not a cure-all, but patients that were walking for 500 yards could now walk 750. You can do the math on that. So it may improve things. Yes, ma'am? Yeah, so cilostazol, 2 main side effects I talk about with patients. A little bit of stomach upset, a little bit of headache. It is a mild blood thinner, but not very strong. We still use it with aspirin, but those are the 2 main things that cause most people to stop taking it. It's not, can't be used in patients with congestive heart failure. So patients that do have heart failure symptoms, it can exacerbate heart failure symptoms, so we are careful not to use it in those particular patients. Many of them in their 70s who have block in their legs also have potential risk for heart failure, so you have to be careful there. Okay. One little quick shout out to some research here, and we are very excited to participate in this study at Duke and actually enrolled many patients over at Duke Raleigh in this study. The exciting piece of it is to try to understand better what is the best blood thinning medicine for patients with leg artery blockages. It seems like we would know the answer to that question, but we really don't. We didn't even test aspirin in this study because there are some studies that actually made us think that Plavix compared to aspirin was a little bit better choice in terms of patient outcomes. So they compared it to a new drug called ticagrelor. I know these names are terrible. The drug companies do it on purpose so you can't remember the generic name, and we'll call it the trade name. But that's also called Brilinta. People have heard of Brilinta as ticagrelor. So now it's been studied obviously well in the heart. This is one of the first trials to study it directly in patients with leg artery blockages to see if it reduces heart events. And then they compared it to Plavix. So that study is finished enrollment. I was actually just speaking with one of our investigators at Duke who's going to be presenting the study. So in the next couple of months, I wish I had that data for you now, but in 2 months we'll know better. And this could be really a game-changing study in terms of how we manage, and those of us that see a lot of patients with leg artery blockages. I may be changing a lot of patients over. I may be telling a lot of patients, stay where you are, but we'll know better in a couple of months. I think it's going to be presented at the big heart meeting. So if you hear Euclid trial in the news getting some press, you can say that you heard it here first before anybody else was talking about it. Interestingly, look at the endpoint. What's the endpoint? It's heart, stroke, vascular events up here, not necessarily leg issues. So I keep hammering that home so many times, but what we're really trying to drive home with these medicines is actually trying to reduce your risk of heart attack and stroke. So a couple months, Euclid trial, be looking for that, okay? All right, and then the last thing I'll talk about treatment-wise. For those patients that fail medical therapy, continue to have really advancing, worsening symptoms, can't walk anymore, really limited in their exercise, or they're getting those rest pain symptoms, or they're getting a wound or ulcer on their foot that's not healing, which could threaten an amputation, those are patients who would be potentially good candidates for some of the revascularization procedures that I and others would offer. That would typically include things like a balloon angioplasty, so where you put a balloon into the blood vessel, blow it up to stretch the blood vessel. There's some new exciting things around around these new balloons that actually have a drug coating on the outside. So when you blow it up, it actually pushes a drug into the wall that helps prevent scar tissue from coming back. So that's an exciting area that's coming now. Stents, also just like in the heart with the medicated or coated stents that have been really advancing the field in coronary artery disease intervention. These are now medicated stents in the legs. It's reducing the risk of scar tissue forming back in these leg arteries, which has been a real problem in leg arteries because the blockages tend to be really long. So anytime you've got a longer lesion, there's a higher risk of a blockage coming back somewhere along that spot. So these new medicated stents are really advancing the field and having people come back, fortunately, for less and less procedures. So less business for us, which is always a good thing for patients. Atherectomy is a sort of roto-rooter device, so sometimes we'll use that. And endarterectomy, people may know someone who's had it on their neck arteries where the surgeon has gone in and done a clean out. That may be appropriate there. Stenting may be appropriate in certain situations. And then patients with really significant symptoms in whom some of these other less invasive options may not be available or may not be good for them, bypass surgery. Just like when I do a heart cath on patients and I decide you need a stent or surgery, we'd make the appropriate choice, whichever one would be best for your care. All right, let's summarize a few points here, and then we'll open it up to some questions. I think just given the time, we'll do questions and skip the case. But it's a common problem. I think I've said that about 5 times. Millions of Americans with the disease, 1 out of 3 patients in their 70s, or patients 50 to 69 with one of these risk factors, which are diabetes and smoking. Thank you, good. A lot of similar risk factors for PAD and coronary artery disease. Many patients have both. Remember we saw that slide before that about half the patients that had leg blockages also had heart blockages. Every other patient that comes to my office that has a leg blockage also has coronary artery disease on average. That's a lot. Many of the patients are asymptomatic, so it's important to pick it up, the exam, and understanding who to be thinking about it in certain high-risk patients. But they still, over time, many of these patients will just experience a decline in lower extremity function. We need to be thoughtful about this when we're seeing patients. Intermittent claudication, that's just a term that we use for patients that have pain in the legs when they walk. That's the most, when patients do have symptoms, that's the most common symptom. I'll say one thing about that. Depending on the level of the blockage, that sort of predicts where the pain will occur. So patients that have blockages higher up in what we call the iliacs, right after the main aorta comes down, the first blood vessels are called the iliac arteries. If you get a blockage there, patients will frequently get pain in their buttock muscles, the large buttock muscles, the thigh muscles, and then sometimes all the way down to the calf. If the blockage is a little bit lower, then sometimes people will just get it in the thigh and calf. And then the most common place actually is more in the mid-thigh. And so by then the blood is not getting to the calf. So it's really the calf muscle that becomes uncomfortable, tightens up, doesn't allow people to walk. And again, the level of the disease kind of predicts in most patients where the blockage may be. All right, if left untreated, obviously, like many diseases, can lead to a decrease in your quality of life. I've hammered home, hopefully, the point about it being increased, there being associated increased risk of heart and stroke events, how important it is to identify and treat these patients. ABI studies, remember I said that was the initial test for us. And if it's really less than 0.9, if your primary care doctor orders this test and it comes back less than 0.9, I think it's appropriate to refer to a heart or vascular specialist who can begin to determine what are the best next steps for you. How do we treat your heart to reduce your stroke and heart attack risk? How do we treat your legs if you're having a lot of symptoms? And then treatment options will vary from lifestyle changes we talked about, smoking cessation right at the top of the list, other medical therapies, the statins, the aspirins, Plavix, maybe some new information coming soon, and then balloons, stents, surgery when it's appropriate for the right patient. Okay?